this day.
Yes. Thank you, Kevin. And now we're going to move to the first presentation on real program experiences today. We're going to have two of them, and it is such an honor to introduce Ken Lueder from New York State. He's going to say a few words about what he did. He's now retired from the job that he totally transformed an organization. But I do have to say that the work that he continues to do, whether it's training, like we've had him train in many states across the country. And each time we've had people say that was really impactful. He has a gentleness about him and a humbleness about him that you will see. And he's also one of the favorite consultants. After we do the 6 core strategies training, sometimes states will have consultants work with different programs to support them on their journeys. And so Ken has worked in multiple states too. And he's always one that's asked for, can I have him as a consultant? So anyway, it's just whenever he agrees to come out of his retirement, which includes a lot of going to really fun music concerts and shares his journey and answers questions for you, we feel thrilled. So Ken, over to you. And that's it, you're on. And,
okay.
And Dana's going to put your PowerPoint up.
Okay. All right. Thank you, Beth, for that introduction. I hope I can live up to your expectations there. Today, I'm going to talk about, this presentation is going to cover the time that I was director of an RTF program in New York from 2015 until 2018. A little bit about myself. I have 42 plus years of experience working with youth and families in residential settings. I've had numerous jobs throughout that time, starting at direct care, working my way all the way up to being regional director of programs. So today I'm going to share this journey of the RTF program here in Rochester, New York. Focus on our restraint reduction efforts. I'll talk a little bit about family and youth engagement, a little bit about the data, and share with you some challenges that we face. Change, please. A little bit about Hillside Family of Agencies. Since 1837, Hillside has been a partner to youth and adults and families facing challenges related to trauma, poverty, and neglect. Hillside uses research-based practices and a consistent emphasis on continuous quality improvement. And Hillside supports communities in a variety of ways by building stronger families and communities, helping youth and adults develop solutions to our challenges, and supporting the work in securing healthier and happier futures. Nearly 2,300 HFA staff provide a robust slate of 100+ services to address the varied needs of youth, adults, and families in Central and Western New York and Maryland. Next slide. Give you a little background about my program. Hillside Children's Center is an affiliate of Hillside Family of Agencies, whose Monroe Avenue residential treatment facility consists of a 34-bed program. The program is licensed by the New York State Office of Mental Health, and I'll refer to that as OMH throughout this presentation. We serve youth from a variety of socioeconomic backgrounds. Trauma histories of youth and families include physical abuse, substance abuse, and a variety of mental health issues. We serve youth from a 19-county area. Youth in the program are 12 to 18 years old. We have 3 co-ed cottages on the campus, and we kind of fluctuate the census in the cottages based on how the units are doing at a given time. If a unit is really struggling a little bit, we'll reduce the census down to 10, and the other 2 units will have 12. We are a voluntary program. And families and youth choose us. They go through a pre-admission certification process where they review the information on the youth and families and then determine whether they meet the admission criteria, and then the information is sent out to the 3 RTFs in the region and they choose us or another program. A little background information here. Back in 2014, our program was not recertified by the New York State Office of Mental Health. We had restraints and aggression was at a very high level. We had many repeat citations. We had an ineffective plan to reduce restraints. We had over 450 restraints in 1 year. Although there was a restraint reduction plan, it wasn't widely shared with staff, so staff really didn't know what was going on. There is also a lack of agency oversight for the program. We just had too many layers and there was just lack of accountability. There was high aggression and a lot of property destruction. Staff morale was low. We had a lot of staff turnover. Youth weren't feeling safe. Staff weren't feeling safe. We weren't very trauma informed. We just focused a lot on behavior and consequences. And as a result of this, we were put under intense oversight by the Office of Mental Health. I was required to submit a weekly report every Friday afternoon on the progress that we made and the trainings we were provided to staff. And every Tuesday afternoon, there was a follow-up call between myself and there is 4 regional representatives from OMH and a couple of central office state representatives in Albany on the call. And those were very difficult calls. And I also say admissions were stopped voluntarily. And I say voluntarily because I did get the heads up that if we didn't stop admitting you to the programs, the state was going to shut us down. The agency also contracted with Beth and Kevin to come in and do a site review in February of 2015. They spent a couple of days on the campus talking to youth, talking to families, talking with staff, reviewing policies and procedures, and reviewing, spending some time in the units as well. And after that visit, they submitted a 28-page report, which I still have filed away somewhere, of the numerous opportunities to make improvements that we should make. Next slide, please. Then our program structure began. Next slide. Myself and a couple of the key staff attended some 6-score strategy trainings. And after attending those trainings, we began to develop a plan to reduce the restraints in our program, including youth and families in this process. We gathered input from staff, we got input from youth and families, and we began to put together our roadmap to move forward. It was important at that time that I really started communicating to staff about some of the changes and why we were doing the changes. The administrative level was flattened out a little bit. And at that time, I was appointed director of the program. We also decided to do away with our traditional model of running the units where we had direct care staff in charge. We decided we were going to put a master's level clinician in charge of the unit where the direct care staff reported to. We also looked at providing administrative support during the evening hours, and we're going to, I'll talk a little bit about that later. Spent a lot of time on staff development and training. One of the things that the agency looked at is that we had 5 different residential campuses, but we did not have an overarching model of how we work with youth and families during that residential stay. So one of the things that we did, the agency adopted a model called CARE, Children and Residential Experiences. It was out of Cornell University, and there were 6 core principles of this model, being developmentally focused, family involved, relationship based, competency centered, trauma informed, and ecologically oriented. At that time, we developed, when we decided to implement that model, it was best practice, but now it's to the form it's an evidence-based model now, and it required 27 hours of training for all of our staff. And now I'll talk about how we use the 6-score strategies. Next slide, please. The first thing, looking at leadership towards organizational change. One of the first things that I did when I became director, I decided that myself and my administrative staff for the program were going to work evening shifts within the program. We were going to spend time in the living units, working alongside staff, supporting the youth, doing observation of staff, looking at what their needs were, getting input from the staff into regards to what do they need. And also these were times to be in the living units, not sitting in your office catching up on paperwork. And you had to work at least until 9 p.m. where we rarely got out at that time. But we made the commitment that we were going to do this. We also looked at, we're going to have our clinicians to begin working evening shifts as well. Spending time in the units, not sitting in your office doing paperwork, meeting with youth, meeting with families, which was more convenient for them, and giving additional support to our staff as well. And we really spent a lot of time listening to staff and trying to support them in different situations. And as we continue to get input back from staff, we continue to develop our restraint reduction plan moving forward. And one of the things that I thought was key, which we failed to do before, was continue to update my staff on what we were doing and how we were progressing along. So that way they knew what was happening within the program, and we were giving them a consistent message that we were going to reduce restraints, with our ultimate goal was to eliminate restraints altogether. And I decided, at that time I would attend every unit's staff meeting on a weekly basis to constantly update them to where we were going, how we were progressing, and also to gather feedback from them. And another thing that we instituted was, I think Kevin briefly talked about the communication and the urgency. We instituted a morning huddle call where myself and my management team would call in every morning at 9 o'clock. The administrator that worked the evening before would give a quick update of what happened the prior evening, and also were there anything that we needed to pay attention to during the day. We would make those assignments, and if we needed to do a debriefing, we would have a debriefing that evening. So that's quickly some of the little things we did from a leadership perspective. The use of data to inform practice. I was very lucky that I had a person in my program who really loved working with numbers. She really liked data. She really liked putting things on chart. We collected a lot of data, but we really didn't look at what our data was saying and why we were collecting it. And we began to gain a better understanding of what the data was telling us. And I remember with those weekly calls with the OMH, them asking, so what is your data telling you? How do you know your staff are using the skills you're teaching them? What is your data saying? They kept driving that in over and over again. So we really started looking at data through a different lens. When you start putting data on different graphs and different charts, it starts telling a different story. Other than I can look at my numbers and say my numbers are going down, we really started digging deeper, looking at, so what's going on behind that? We look at day, we would look at shift, we would look at time, who's working, the experience level of who's working, the phase of treatment that youth were being in. To start really digging deeper, one of the things that we noted, a quick example, is we had one of the living units that we noticed that right after school and before the evening began, that's when a lot of incidents were happening. The data was telling us that there is a lot of incidents happening in that unit during this time. And through our observations and digging deeper at the data, what we were finding out was there's a lot of downtime when the youth came back to the unit. Staff were spending time planning off the shift for the evening, and you had the youth getting bored, and then they would start acting out or getting into trouble or whatever. So we decided that prior to the beginning of each evening shift, a half hour before, they were going to plan the shift out. So when the youth got there, they're welcoming them as they came in the unit, and then they transitioned smoothly right into the evening shift. So by doing that small change, the incidents started going down during that time as well. And, you know, we would look at sometimes the experience level where all of a sudden a lot of incidents were happening on a certain shift. And what we found out, our newer, most inexperienced staff were working on that shift. So we made some schedule modifications to address that issue. Each unit also had a weekly incident review where they would review the incidents that occurred in that unit for the week, and then they would come up with plans to address that to make sure incidents weren't going to happen again. And that was shared with all of the staff. And on a monthly basis, my management team and I did a higher level review of the incidents and the trends that were going on. And from that, we would determine whether we need to make changes to the program, whether there are policy changes, where there are rules and expectations that we needed to look into. So we did review that more from a higher level. And we also instituted, to share the data with staff, we would print out a chart once a month that showed the progress the unit was making on reducing restraints and aggression. And also we had the program's use of restraints and aggression. And that was posted in the staff meeting each month at the beginning of the month. Some use of restraint and seclusion prevention tools. One of the things that we did before staff entered the program, we would ask the kids, so what do you do when you want to calm yourself? If they said they wanted to draw or whatever, or they like to listen to music, we would put that in a welcome basket when the kids came into placement. We also had the clinician would do a trauma assessment at admission, and also we do a safety plan at admission where any medical concerns were noted in the event a youth was put into a restraint. And also in the welcome basket, you know, we would have their common items when they came in, along with some program expectations. We also spent a lot of time updating our environment with that high aggression and restraints. There was a lot of damage and the units were really run down. So we spent some time involving the youth in updating the environment. Some of them actually worked with the maintenance department to fix some of the holes they put in the walls. The youth were able to choose the color of the common areas and their bedrooms. We also updated the furniture on the units. And one of the things we did, we had a couple of samples from our vendors and we actually put it on the units and left it there for a couple of weeks and let the youth decide which furniture they wanted on the unit, which one was most comfortable for them. We also put individual lockers in place where youth could store some of their personal items and their soothing supplies. So in the event that they felt themselves getting upset, they could go get their calming supplies themselves and not wait for staff to have to get them for them. We also put up youth artwork throughout the unit. Youth really took pride in this. We put music speakers throughout the hallways and the common areas. So during times of transitions, when we wanted to settle things down, we could play very soothing, quiet music in the background. And we also had a sensory room on each unit. And the youth decided what went into those sensory rooms, whether it was rocking chairs, glider chairs, beanbag chairs, music stereo, or other sensory items. The youth chose what went in there and they could use it at any time. I'm going to go back up to workforce development. We spent a lot of time developing our staff, you know, doing the evening shifts. We asked staff what they needed to do their job, and we also could observe some of the things that they needed. We also looked at what our data was telling us. Why were staff getting into these interventions? What type of trainings that they need? We spent a lot of time providing all different sorts of trauma training for our staff. And like I said, the implementation of CARE was another additional 27 hours of staff training that they got. One of the questions that OMH had asked was, how do you know staff are using the trainings you're teaching them? What we created was a staff observation sheet where the administrator that was working evenings, we all determined that we would do a certain number of observations during the month's time, and we would pick out the skill each month that we were looking for. And during our, nightly working, we would do a quick, maybe 10, 15-minute option. There were spot observations to see if staff were actually utilizing the skills they were being taught. And then we'd give them quick feedback of what we saw. And if there were issues that needed to be addressed, we would pass it on to their supervisors. A quick example of something that a basic one we started was looking at how are staff interacting with youth. Were there positive interactions? Were they negative? Whether they were too controlling, or were they just sitting back watching things going on? We would do that observation and then pass it, give them the feedback from what we were seeing. Another thing that we thought that was very key in the staff development process was making sure that staff are getting supervision. One of the things we also created was a supervision tracking form where supervisors would document the dates that they met with their staff in supervision each month. They would submit that sheet to me at the end of the month, and I would just randomly pick a couple of dates and say, send me your supervision sheet. Twofold I could look at to make sure supervision was actually happening on a regular basis, and also look at what issues were coming up in the supervision with staff. Were there additional trainings our staff was needing as well. And also I found from that too that some of my supervisors needed additional training as well. So that was how we were making sure that the supervision was happening. And we also kind of tweaked our hiring process. We had potential candidates meet with the administrative team of each living unit. It was the clinician, supervisor, assistant supervisor, and they would interview the potential candidate. And after that interview, we would then send them to the living unit where they would spend a couple of hours on the living unit. And then from that, we'd get feedback back from the youth in regards to what they thought about this staff person. And 9 times out of 10, the kids were right on target with who they said we should hire. So we really included a more inclusive hiring process. All right, looking at debriefing strategies. After a restraint, youth and the staff are debriefed before the end of the shift. We have family members who can participate by phone if they so want to. After that initial debriefing, we have a administrative debriefing within 24 hours. The membership of that debriefing committee would be myself, my psychiatrist, the 3 clinical managers, the staff involved in the restraint, the family advocate. We had a nurse manager, staff involved in the restraint, and parents participated too. If they happened to be on campus, they sat in. Otherwise, we would call in and they would participate by phone. We did a very thorough, very rigorous debriefing because, restraint should not happen, and we were going to do everything within our power to make sure they would not happen again. We really took it apart and looked at, is there something that we missed? It could have been something 2 days earlier that was the precipitating factor that we missed. So we did a thorough dive into the restraint. And after that, we would come up with a plan, and then that plan was taken back to the unit and shared with staff. One of the unintended consequences of that, it wasn't a blaming meeting, but for staff, we asked some really difficult questions. Was that restraint really necessary? Is there something that you could have done differently to prevent you from putting hands on? And I think one of the unintended consequences, which was a good one, staff started thinking before putting their hands on kids. It's like, I don't want to sit through that meeting again, but so is there something else that I can do to prevent this from happening? The consumer roles in the inpatient setting. Next slide, please. Tell me and I forget, teach me and I remember, involve me and I learn. Next slide. Right from the screening, we tell people, the families, we're an intervention in the treatment process, that we're a family involved program. We talk a little bit about attachment theory, how separation created by residential placement is not optimal for growth, and optimal growth happens with primary attachments, which is the family. We defined our length of stay as 3 to 6 months. We expect our parents to have daily contact with their youth, whether it's in person, by phone, or through comfort calls. If they don't have the computer equipment, we will provide that for them. We also expect that families will have at least weekly face-to-face contact with their youth, either in the program, home, or communities. Families can call their youth at any time. We did away from the 6 to 8 p.m. phone call time. They can call their, talk to each other at any time that they want. And actually, some of the youth calling their families is a soothing technique when they're becoming upset. Families can come up and visit their youth at any time. We just ask that they call ahead of time, so we'll make sure their youth are still there. We started changing our language. One of the simple things was kids don't go on home visits. They go is home time. They're spending time with their family and they're visiting with us. Families can participate in any activities we have on the campus. For families who are from a great distance, or for some reason, whether there's a protective issue, they cannot visit in the home, we will put the families up in a hotel here in Rochester for the weekend so that they can visit with their youth. We do provide transportation for home time. We have agency vehicles going out throughout Western New York on Fridays, dropping kids off at different drop-off points, and we pick them back up on Sundays. We ask youth can choose the color of their rooms prior to them coming into placement, and we'll have their rooms set up for them. We ask them about their common items, which we put in their welcome basket. And one of the things we do to speed up the admission process, our intake person and family advocate may go out to the family's home ahead of time just to sign some of the paperwork to make the transition a lot smoother. On the day of admissions, family helps their youth settle in. We'll provide a meal if they need the meal. They can take their youth out in the community if they like. They get their welcome basket with their common items and other items, and the youth on the units, put a sign up on the door, welcome them into placement. Families meet with the clinicians and they begin developing their goals for discharge and treatment planning. We, minimum of 2 family sessions a month, but we encourage our clinicians to meet with the families in their homes and into the community instead of having them coming up to us all of the time. We talk about the treatment conference schedule at that time, and we try to accommodate families' needs more instead of having them come up to us. We're having those in their homes as well. Next slide. We're going to talk a little bit about youth involvement. We do have a youth advisory board that is made up from representatives from each of the living units. They meet with myself, another staff, and the youth mentor a couple of times a month to talk about the program, what's going well, what's not going well, things they want to change, any ideas that they have about changing the program. They know they have their time to meet with us. We have a youth and mentorship training program where we send youth out in the community to get training, become mentors. And of course, youth participate in their treatment conferences. And we actually have youth running their own treatment conferences when they're able. They're involved in policy development. There was one policy where youth weren't allowed to have pets in their rooms. They thought it was unfair. So the advisory board got together. They developed the policy and submitted it to the agency, and the agency reviewed it and agreed. So now youth can have pets. They have goldfish, they have turtles, they have rabbits, and there's one kid actually had a little hairless rat, which I thought was, wow, never seen one of those before, but they made this happen. Youth also sit on different committees throughout the agency, and they are involved in the hiring process for staff, whether it's sitting on panels and giving input. Next slide, please. I'm going to go through some staff expectations quickly here because we're getting close to time. The clinicians responsible for treatment planning and therapy required to meet with their family in their homes. They're required to work the evening shifts once a week and also once a month. They have to work a weekend shift once a month. They do treatment conference planning, and they begin to use family therapy, which they lack a lot, especially with the families of great distance. And they're also responsible for permanency and getting additional resources for the family. We also have a transition coordinator, and they work closely with the family to begin planning discharge at admission. Their primary role is to work with the families in their home and community. They create the home safety plan, which they update on a monthly basis or as needed. They identify barriers to discharge with the family and help them work through their barriers. They're also a link to community service to support the reintegration of the youth and family back into the community. And they're the ones that have the flex funds that can help the family have their kids return home. We also employ a full-time family advocate. This is an additional support to family members. They meet the family at admissions. They're present the day of admission. There's an additional support. They also locate the community resources within the different communities that we serve to better support the families. They also help the families advocate to get their needs met and to make sure the family voice is heard in the program. And one of the things I talk about our direct care staff, we did see a big change in the direct care staff because of all of the training and additional support and listening that we provided for them. They're making sure that they're getting the supervision that they need and the support that they need, and they're really proud of their work. And that showed up in one of the reviews that we had subsequent to starting our journey here. There's a big shift away from blaming the families, looking more being trauma informed. And one of the things we did with our direct care staff that I think helped in the reduction of restraints, we started looking at the rules and expectations in the program. We had hundreds of rules in the programs. Rules should only be for safety. And once we start looking at that, I can almost count the number of rules we had on my hand. Everything else is an expectation. And I think in crisis situations, staff were able to look at whether the youth was ready, willing, and able to follow the expectation. And they had the ability to drop that expectation if it was going to prevent a conflict at a time. With our recreation therapists, their focus changed from providing activities on the main campus to meeting the individual needs of the youth in the communities. If a youth was interested in an activity or were part of an activity before they came to us, whether it was music lessons, gymnastics, volunteering, we found that in the community for them so they could continue to do that. We also had the rec therapists find recreational activities in the home communities of each youth that the families could take their youth to. And we looked for stuff that was free that they could do as well. We did have a youth mentor in the program, and that was just an additional support to the staff that we have. Additional support to the youth. Okay, I know a couple of minutes left. We have 23 family advocates at the agency, 3 youth mentors. We have family members on the board of directors, and they serve different committees throughout the agency. Next slide, please. With our restraint reduction efforts, we were able to reduce our restraints by 90% in this 3-year period. We went from well over 400 restraints going to 40 to 60 restraints to some months. We were able to reduce by 90%. We had 2 of the 3 units that were 8 months without any restraints, and aggression was reduced by 75%. And when I say aggression, that's physical, verbal aggression, property destruction, and homicidal behavior. Next slide. Some of the challenges that we face with length of stay, we wanted to get down to 3 to 6 months. At the second quarter of 2018, we were down to 7.9. We really need to work on continually engaging parents better in the program and increasing family voice, and also teaching them to understand trauma as well. Sometimes families wanted us to punish their kids and not really look at what was behind the behavior. And one of the things that I can say in closing is remember to reward your staff and recognize your staff for all of the hard work. One of the simple things we did at the beginning of each one of my management meetings, we would identify a couple of staff who've done something good during the week from our observations and just write a quick note to them on a certificate and present it to them in a staff meeting. That's easy to do. Remember, this is a journey. Change is not going to happen overnight. Keep your eye on the goal, and using these 6 core strategies as your roadmap, change is going to happen. And the strategies will work in any setting, whether you're working residential, community-based, school, hospital, working with youth from the different systems or adults. It will make a difference. And thank you.
Oh, Ken, thank you so very much. So much information there. There's going to be an opportunity for the audience to ask questions after the next presentation for a half hour. So if you could make yourself available, go on mute now, but then make yourself available after the next presentation for people to ask questions. And we want to encourage everybody, if you have questions for Ken or the next presenters, to put them in the chat box. If you want to remember them, like if you're old like me, even though I look young, you might want to, just write yourself a note or put it in the chat box, and then we'll have them available for Q&A. And then Kevin, you want to introduce Mary Louise? Do we want to do a break, or do we want to do questions for Ken?
Oh, we can do questions, sure.
Yeah, why don't we do any kind of questions or comments for Ken at this point? Just to start off the questions, I want to say there were so many things, Ken, that you did that were near and dear to my heart. But one of the things that I really appreciated was how you changed the role of the rec therapist to really focus on the individual interest of the children. And at one point, I think you had every single youth in the program engaged in a community activity that matched their strength or interest. Is that true? Something like that, like everybody was there.
Well, that was our goal, was to find out, because we did an initial recreation assessment too when they came in, to identify what their interests were. And then from there, we would try to match them to something in the community. Like, I said, we had youth doing gymnastics, whether it was in the Boy Scouts. We had youth that had volunteered in the past, that we had them volunteering at local food shelters. We had them volunteering at the animal shelters. But yeah, that was the goal, was to match individuals with their needs and put it in the community. And there was that big push from not having everything on the main campus to having it in the community, because when they were returning home in the 3 to 6 months, we wanted to have a smoother transition for that.
Great. Does anybody have any questions or comments for Ken? I don't believe I see anything in the chat box. Anybody have hands going up there? I don't see any hands.
Hey, I'll just jump in.
Oh, Brenna, welcome back. We love your questions.
Oh boy, that's a lot of pressure. I was going to ask a really dumb question this time. No, so thank you so much. I feel like that was really helpful. And one thing that I wanted to know is, when you were starting to implement these changes, did you run into any staff resistance initially? And if so, how did you kind of bring those folks on board?
Yes, funny you should ask that question. Yes, initially there were some staff resistance to some of the changes that we were making, and we found that more so with some of the staff that had been around for a while, that they were used to doing things a certain way. And one of the things we did with them is, like, we worked with them a lot in supervision around, these were the reasons that we're making the changes. This is why we're making the changes, giving them the opportunity to voice what their concerns were. Also looking at, were there any additional trainings that we could provide for them that would support them? And one of the things that we realized, that at some point there were some staff that we were able to change their way of thinking, and they became on board. And there were others that, for whatever reason, no matter what we did or how we tried to support them, they did not agree with the direction of the program. And at that time, we made the decision that we were going to part ways with them because that was not the direction that we were heading in, and they weren't going to change. There were different programs on the campus or within the agency that they could apply to, but they weren't a good fit for our program. And that was a decision that we made early on as a management team, that if you weren't on board with the changes that we were going to make, that we're going to make some tough decisions. But we tried to support them. We tried to convince them to change their thinking, but some people just didn't.
Yeah. Thank you, Brenna. And I think the thing, Ken did not go through COVID at the program. And we know that COVID, the pandemic really devastated staffing for many of you. But I know that when he took over this program, there was a lot of reticence. People left because of some of the expectations. This was very early on, Ken, as I remember. And there was that element of being really down staff and the senior staff having to work shifts. And, I just remember it was pretty chaotic. So there was a similarity to that. But I was particularly appreciative of how you focused on the supervision of the staff and that on mentoring every evening, that people were there to mentor and to give feedback. The other piece that, Ken, if you would speak about is this, that we really want to have a theme throughout this, this entire, as Kevin said, the theme of trauma-informed care, the theme of youth voice and adult voice and choice and roles. And you hired both family partners and youth mentors. And so just maybe a couple more, I know you talked about it, but anything else you want to share about how important those roles are and how it actually ended up supporting the staff as well as the families and the youth?
I think one of the things with the family advocate that we hired, and this was a person who had lived experience, they had a child that had gone through residential treatment. I think one of the things that it helped was that this person attended a lot of our staff meetings as well. And they were able to share from a firsthand perspective to our staff what it was like to have a child in residential placement, to have a child that was struggling, and also sharing with staff. We would have them, do different trainings on how to communicate with family members, how to feel empathetic to them, that it's not their fault that their child is in placement. So this helped staff look at families from a different perspective. They were available to staff to talk with at any time if a particular staff was having a challenge communicating with staff, a family member. They would work with them on different ways to how to connect with family members. And with the youth mentor as well, that person working with the youth in the program kind of gave them a goal towards something that they could work for, that residential is not that bad. If you take advantage of the help that's being offered to you, good things can happen. At times, the youth just couldn't talk to a staff member for whatever reason, but this youth mentor, they could share the information with the youth mentor that was then passed on to the staff for us to address. But by having the family advocate and youth mentor, I think it really improved the youth voice in our program and how we looked at things. Whenever we were changing procedures or a policy or something, we always got their input, and it made us start looking at things from a family perspective sometimes in other instead of thinking that we're the experts in everything, the families are the experts with their kids. And it just changed the lens that we started looking at things through. And I
Thank
think
you.
that was a very positive addition to the program.
At which they've expanded. From
Yeah.
what you said, it was so positive that they've expanded it. Does anybody else have any questions or comments? Because the next presenter, something must have happened, so I'm not sure. We've never actually not had this happen with one of our main presenters coming up. But what we're going to do is we're going to, if nobody has any comments or
I
questions.
think there's one from.
Oh, okay. Yes. Who
Hi,
has
thanks. So I had a question about how do you engage or work with parents who primarily see your program as a respite program for themselves, who are just sort of treating it as I'm just going to, drop my kid off here and you're going to take care of everything and you're going to handle everything for them. And I'm just going to keep them there as long as I can and, delay discharge so that I can have some respite. How do you engage with families like that?
That has been a challenge at times with us because we've had families that say, yep, I'm dropping my kids off. It's taking me forever to get them in placement. You're going to keep them for the next year. And then we work really hard to engage them. We utilize our family advocate a lot to spend times with the parents. We had one particular family member who dropped their youth off into placement, and they said they're never coming home again because I don't feel safe with my youth coming home because they may be aggressive towards me or younger siblings. One of the things, it took a while to get this in place, but one of the things we started doing was having the supervised visits with the family member on the campus. And then we slowly worked towards sending a staff person with the youth to meet, say, at a local restaurant to have a meal, to really start engaging and supporting them. And we slowly worked towards having a staff member go to the home with the family for a quick visit. And as that progressed, we would have the staff person sit in the driveway in the van while the youth visited with the family. The next step was we would park the van down the street and help the family feel more supported and engaged. And we even worked towards having the youth do an overnight stay with the family. And we actually had a staff person that actually stayed in the home for the overnight and eventually worked until the family was feeling safe having the youth back in. A lot of times it's looking at identifying why and looking at the trauma that happened, why the family is saying, I don't want this child back, and how do you address those issues? It's difficult at times, and the family advocate has been very supportive along those lines as well.
So we was something you mentioned in your scenario you gave me that's very helpful, but something you mentioned reminds me of a case we recently did have where we did just that. We did the very slow transitional thing. We had the staff at home, then we had the staff down the street. We did the whole thing. We did a lot of coaching of the parents on de-escalation strategies. And then what would happen is when the child had home time, as you call it, which I like that, if the child became escalated, the parent would call the program and one of the family support staff would be available and say, okay, here's what you need to do to de-escalate the child. And they would just downright refuse to do it, even though we've worked on this.
Right.
You know what I'm saying? And so then the problem was they would say, well, I don't want my child home because I don't feel safe with them home, exactly like you said. And then they themselves would refuse to do the things that would get the child into a safe space. I don't know if you have any experience with that or if that's such an extreme case that, working on things like that is still a work in progress.
No, we've had, another family that no matter what we did, they said this child is not coming home. And that's when we started looking, are there additional resources for this child as well? We went through the family finding process. We're looking at identifying different relatives on the mother's side and the father's side who may be an option for this, or we've even looked in foster care where it was a transition where the youth left our placement, ended up in foster care or with a family member before returning home to the family. So it was kind of a transition stage to get him there, because residential wasn't the place that the kid needed to be. You know, they met all of their progress, and we had just had a difficult time engaging the family. So what we did was look at other options for discharge for this particular youth.
Okay, thank you very
Okay.
much. Appreciate it.
Thank you. And great question, Brennan. And I always think about a family partner who worked in a program such as, and Ken's program is called an RTF, but it's the same as your IRTPs. It's hospital-based residential program. In, you know, Massachusetts, they call them IRTPs, and in New York, they call them RTFs. But I remember a family partner that said that the parents, when I interviewed the parents, said, she had me at hello, you know, that we want to get those family partners that can engage so much. And Ken's clinical staff moved from everybody had kind of a standardized approach where they used this one approach with all families to an individualized approach. So it was an interesting too, how the clinical staff changed in that process. So we have another question, but I think what we're going to do is take a break now. If people have other questions for Ken, we can ask him. He doesn't have to stay on after the break, but we can get back to people tomorrow. I'll email him those.
I can stay on.
Oh, okay. Well, we're going to take a break now. If everybody, we're going to take like a 15-minute break. And so remember, you got to stand up. I know it's a little bit, you know, different. Oh, Janice, did you want to say something? I know you have a question there, but I was feeling like we take the break and then come back for the next one. Did you want to ask, Janice, or do you want to go ahead?
I'm trying to speak with Mary Louise White, so I'll hold my question. Thanks.
Oh, okay. Okay, so break, people, and then we'll come back. And thank you, Ken, so much. Thank you for the questions, folks. And onward, 15 minutes. So see you at 25 of.
Okay, so we did a quick change. Unfortunately, Miss Mary Louise White and Karen are not available at this moment. So I'm going to go ahead and do the project that we did at Bridgewater State Hospital. And so I'm just going to go ahead and start now. I'm going to go fairly quickly since we lost about 5 minutes. So again, Bridgewater State Hospital is in Massachusetts. And as such, I spent a good 2 years plus working with the staff and my team there. So next slide. So what happened quickly is that back in 2016-17, Governor Baker had become very aware of some of the issues that were going on at Bridgewater State Hospital, which is one of only 2 forensic facilities in the country that was being run by the Department of Correction and not the Department of Mental Health, even though the person served there had serious mental illness and co-occurring disorders. So he mandated that the Department of Correction contract with an outside party to come in and start to transform that facility from a prison to a hospital. Next slide. So part of that mandate included the reduction of the use of seclusion and restraint. As part of that, everybody would have an individualized treatment plan, which in a prison you do not necessarily have, and that we implement quality clinical programming that would help the person served. That's what we call the patients at Bridgewater, meet their treatment goals and move on either back home or to where the courts indicated they needed to go next. Next slide. So one of the first issues that we did, and I was part of a team and an organization called WellPath Recovery Solutions. And WellPath Recovery Solutions is well known in the country as working with troubled hospitals and in many cases taking over private public state hospitals. So the first project I did with them was back in 1998 at South Florida State Hospital, where I think I told you at the very beginning of the first day of our training, that is where I learned a lot about how to reduce the use of seclusion and restraint. So one of the first things we did, remember we talked about looking at a vision. So we both revised the mission and the vision statement. The vision being making recovery real, helping people with mental illness realize their full potential one person at a time. Next slide. So the first year initiative includes all of these components, and I'm just going to move forward and move more into the seclusion and restraint piece. Next slide. So Bridgewater State Hospital serves people with serious mental illness who require strict security, usually because of their charges. We came in January of 2017 and took over operations fully on April 9th in 2017. We had a 600-item transition plan. Each of those tasks was assigned to a WellPath lead staff person. And we worked very closely with Department of Corrections from the minute we came in January to now. Next slide. The first thing that happened, which was extremely significant, was that we were allowed to change out the correctional officers, which were Department of Corrections staff and prison correction officers, with people that were trained in working with folks with serious mental illness. And the reason that was so important was because prisons have very different goals and objectives, and they are very often control and containment and safety over everything else. So behaviors that were troubling or even reached the level of dangerousness were managed in a very different way in a prison than how you would manage them in a hospital. Next slide. So very immediately, we replaced the correctional officers with therapeutic safety technicians and recovery treatment assistants. These were all trained mental health staff, which is the first step in moving this from a prison to a hospital. It was a huge leap of faith. There was a lot of doubts on the part of the Department of Corrections and even some folks in the governor's office, whether or not we would be safe and effective in making this change. But it was. And we also then closed the intensive treatment unit on April 10th, which was the day after we took over fully. And just to let you know, the intensive treatment unit in the old Bridgewater was a place where every single person served would be brought to if they did anything that was concerning to staff. So that could be everything from swearing to spitting to refusing to obey an order, to not getting out of bed, to refusing medication, to walking off the sidewalk without permission. So it was a very restrictive environment, and everybody would be brought to the intensive treatment unit away from their home unit if they were seen to be a problem. And in that intensive treatment unit, everybody was either in seclusion or restraint. Next slide. So we saw, as you can imagine, pretty immediate changes. And that is because our direct care staff now knew and were in charge of really responding to anything that they were concerned about, also in terms of the patients, but they also were trained very clearly in what imminent danger was and what it was not. They were also trained very well in de-escalation techniques. We brought in a completely different vendor that really focused about 75% of that training on de-escalation, mediation, negotiation, and how to avoid putting hands on anyone. And everyone got this training going forward during a week-long orientation for new employees. They also learned very quickly that one of our vision components was to really prevent ever putting hands on people because of, obviously the sequelae after that kind of event happens. And that these folks were all already pretty traumatized through their experiences, both outside the hospital and inside the hospital. So we really had to focus on creating a much more trauma-informed environment. Next slide. Next slide. So early on, we recognized that the hospital, because it had been in prison and under DSC, really wasn't familiar with the National Hospital Patient Bill of Rights. And so we adopted that and incorporated it in our daily work. We also adopted the Massachusetts Department of Mental Health grievance policy and procedure, which also was new to the facility. And we received support from Department of Corrections, obviously, to do this work. Next slide. 99% of the people admitted to Bridgewater, we found had serious and significant trauma histories, everything from abuse, neglect, constant exposure to violence, fear for life, prison experiences, substance misuse, poor attachment to caretakers as children, and untreated serious mental illness, just to name of some. Next slide. So in addition, we revised over 200 policies. We eliminated a number of internal regulations and rules. Just one, which is just one, was the fact that people weren't allowed to step off the sidewalk when they were out in the big day area. We also really clarified that staff could not speak in any kind of harsh or angry language to people. And followed up with that and really made it clear that any kind of behavior that could be seen as abuse or neglect was a terminable offense. Next slide. Care without judgment is a core WellPath value, and this was critically important for us. What it meant that we trained staff to treat every single person the same way. We didn't care about the legal charges, and most of those we couldn't even look up. The legal documentation was kept for only the forensic psychologists because there really wasn't a need for everybody to know everybody's charges, obviously. So we really based treatment on the individual symptoms and behaviors. We also trained staff to give persons served the benefit of the doubt. It was a big change for the people there to have this whole new group of staff come in. We also did a lot of work with language. Next slide. Next slide. So speaking of the 6 core strategies, we started to implement the 6 core strategies pretty quickly. Under leadership, again, we defined what imminent danger meant. We implemented MANT training for all staff in orientation, and we chose MANT because they had incorporated an enormous training component on trauma-informed care. And we really felt that was important. We also put senior leaders on 24/7 call to be notified of any events that occurred all through the day, evening, and night, and also on weekends and holidays. Next slide. Continuing with leadership, We also implemented that daily morning meeting that included all the clinical leaders and reviewed every unusual incident from the last 24 hours. We asked a lot of questions. We would follow up. Sometimes the follow-up would be with quality improvement. Sometimes it would be with the individual staff that were involved. Sometimes it would be with the individual patient. Sometimes it would be with the whole treatment team, but we would drill down every single day on what had happened that last 24 hours. And that fed into our revision of rules and policies. We then also looked at our data gathering and analysis, and we began collecting reporting on all adverse events in a database. Staff collected that data in the individual units on use of seclusion, restraint, manual holds, involuntary medication, any kind of injury, workman's compensation claims, and anybody that had to go to the hospital. And so we started gathering a lot of data that was very available to all the leadership that we could look at any time. Next slide. Workforce development. Again, like I mentioned, we completely revised our onboarding for new staff, and we retrained all the staff that were in place already with a focus on trauma-informed care, customer service, recovery and advocacy competencies, advanced MANT for certain staff that demonstrated advanced skills in de-escalation. We revised and trained on our new mission, vision, and values, and our new seclusion and restraint policy. We added nurse managers, which there hadn't been before, and supervisors for direct care staff to help role model, mentor, coach. And we put in lead our recovery specialist staff and our quasi-security staff, our therapeutic safety technicians. And those lead staff circulated throughout their entire shift and were on call for any unit that was starting to see an escalating problem. Next slide. Under prevention tools, which we'll be talking about tomorrow, we implemented a number of assessment questions into the admission procedure so we could start to kind of highlight people that we thought might be at more risk for escalating behavior and difficulty in managing emotions. We implemented comfort rooms. We hired occupational therapists to help us understand how to use sensory information and create calming plans that would sometimes use sensory equipment and supplies. We implemented assessment tool for suicide prevention. We hired a patient advocate whose doors open all the time and who follows up with anybody that has a problem issue. And we started different kinds of therapeutic programming with input from the people being served at Bridgewater. Next slide. Also under prevention tools, we were trained in person-centered planning, and that process is still underway, but it's obviously much farther implemented now that it's 2023. So the Bridgewater's been under WellPath management for almost 6 years now. We also did away with the token economy program and instead implemented just an incentive program that was based on safety only. So that would provide patients with access to the off-unit programs and recreational activities. Green was full access, blue is access with staff escort, and yellow was restriction to the unit. And this was early on in the process to start to change the culture. And as that got implemented, the actual access program actually kind of went away. It's now just kind of part of daily business. Next slide. We began almost immediately to expand the family support group, which was a very, very small group of people to begin with and expanded fairly quickly. hired peer support specialists that were certified and extremely skilled. And you're going to hear from one of them at the panel at the next session. The peers also started working with persons served on admission. And they also do they hold individual caseloads. They do a lot of group and therapeutic activities and help the advocate respond to grievances, attend rounds and team meetings when needed, and everything that you would expect a peer support specialist to do. We also started a person-served governance committee that very first year and invited 2 representatives, 2 patients from each unit to attend monthly meetings. And those meetings were run by either the person served, the Bridgewater State Hospital advocate, or back when I was there, I would run the meetings. So, or one of my colleagues would run the meetings. And during those meetings, we would basically ask, how are things going? What's going well? What's not going well? What can we do to make your stay here better? Out of that meeting came a number of recommendations. One of them was the opportunity to have a meal with your family during visiting hours in the family meeting room, where families could order in food and meet with their loved one and have a dinner or a lunch. And that was just one of the issues that came through. Another was what they could wear. When we took over at Bridgewater, everybody that was receiving services at the hospital was wearing Department of Correction jumpsuits. And we were able to negotiate with Department of Correction and move to regular clothing. And that came out of this person served committee just that first year. Next slide. Rigorous debriefing. This was critical. Obviously, the daily safety huddle in the morning was the first step in identifying the different events that required more analysis. And then we ended up doing a pretty thorough debriefing policy and procedure that included an immediate event debrief of like a huddle right after the event by everybody that was involved, and then a formal debriefing with the treatment team within the next 24 to 48 hours. Next slide. Next slide. An important piece was that language component. When we got there, people were speaking in Department of Correction prison language: chow, count, inmate, mentally ill person, cells, lock-ins, booking, traps. And so we changed that language to what I would call softer therapeutic behavioral health language, which I don't have to read it to you. And that went a long way also, I think, in helping people change minds and attitudes. Next slide. DOC, again, we couldn't have done this without them. And actually DMH was also great partners in sharing policies, procedures, and all kinds of information whenever we needed that. We also had access to all the video cameras in real time, as did DOC. Next slide. These are mechanical restraints, and this is just from the first year, but you can see if you go over to the left side, it was quite high. And the minute the correctional officers transitioned out and we closed the ITU, the numbers dropped really significantly. Next slide. This is seclusion. These numbers actually were shocking to me. When we got there, we found that the average use of seclusion was being counted at 5,000 hours a month for 275 patients, which is an extraordinary number of hours in seclusion. And as you can see, again, within that first month, we saw this huge drop due to the implementation of trauma-informed care and the changeover of the correctional officers and the immediate training for all staff on what imminent danger actually, what that threshold was. And that many of the behaviors that people had been secluded over didn't come even close to reaching the level of imminent danger. So that immediately went away. Next slide. We also worked really closely with our rehabilitation services to incorporate much more therapeutic activities. We did have to buy a lot of equipment and supplies, but most of that stuff doesn't cost a whole lot of money. And so we were able to really implement fairly quickly on unit and off unit groups. And we really were open to just about anything that staff wanted to do. If they had a skill in songwriting or yoga or Tai Chi, we implemented it. And we also spent a lot of time with staff on working with their own wellness and implemented a wellness program. Next slide. Next slide. Okay, so I am going to end here and move toward, we think we have about 2 minutes for any questions, and we can also please hold your questions if we don't get to them right this second, and we can do questions at the end. Let me check the chat. Please feel free to write in any questions, folks.
Kevin, great job. I happen to be gifted to have seen Kevin in action at Bridgewater, and I have to tell you that she just kind of came in and brought compassion and kindness and thoughtfulness and a understanding and wisdom about each of the 6 core strategies, and just literally was working 16 hours a day to do this transition, and at least 16 hours a day, and it worked. So just wonderful, the good work you did. And including, we're going to have one of the peer workers from Bridgewater on the panel that's coming up next. Thank you,
Thanks.
Jeffrey. Okay, Dana, I think we're ready then. Okay. We actually are going to start with the panel. And again, as Kevin shared, if any of you have questions for her that you think about, put them in the chat, jot them down. We're going to have an opportunity at the end of the panel for questions. So it's an honor to serve as the facilitator of this panel with 3 people that have firsthand experience as a consumer or client of behavioral health services, as a child, adult, and or parent. And now they serve as peer partners or advocates for others who are currently experiencing behavioral health services. And I'm going to have them introduce themselves, their name, their title, and the focus of their work and how long they've been there. And then I'm going to share a few other things about them. But first, just an update. We had another peer who was supposed to be on today, and she texted me this morning that her dog got hit, her therapy dog got hit by a car last night, and she had to be there at the vet when they put him down at 11. So she says she's so sorry she's not able to be here with us, but she wanted to let you know. So if we can start, Morgan, if you could just share your title, the focus of your work, and how long you've been in your position.
Hey, everyone. Welcome. Thank you for having me. My name is Morgan Neal. I'm a peer specialist at Bridgewater State Hospital. So I work with men, and I have been here for 2.5 years. My focus is really on treating everyone with compassion and not going in with any judgments, any preconceived ideas. I don't look at legals. I have the option to, and I don't. So my work is really treating everyone as they should be treated as a human being. So thank you.
Thank you, Morgan. And why don't we move, because you're on my screen next, Sam. So why don't we move to you with your name and title?
Hi, everyone. I'm Sam. I work as a peer mentor with the NAN Project, and we go into high schools and middle schools and share our stories and help to destigmatize the challenges around mental health.
Okay, thank you, Sam. And Michelle, not last but not least at all. If you turn on your audio, Michelle, it's still off.
Thank you. Something I always do.
Okay.
I'm Michelle, and I work at the Children's Home of Wyoming Conference in Binghamton, New York. I am a family peer advocate here. I work on residential treatment centers, and my job and my focus of work is to establish relationships and support the parents through their journey from admission to 6 months of aftercare. And I also formulated with my supervisor a support group for the parents here.
Thank you, Michelle. You know, a few other things about these three panelists is, of course, they've each had their own experience in different systems and then went on to become peers to support others. And that may come up or may not come up in the questions that are re-asked. But in addition to what Morgan said she did, I asked them to tell me what their friends would say about them. And just so a few things about Morgan that her friends and her partner shared. She's extremely empathetic, supports people from unserved communities, understands their values. She has tremendous loyalty, always shows up for people, no matter the circumstances, and helps them feel loved. I like how their friends included that. And she's resilient. She perseveres through her own trials and tribulations and doesn't give up. And she, just so let's have some lightness here too. She loves to sing and acts, musical theater. Maybe she'll do something for us today. But then she also watches basketball and plays video games. So just, you know, a human with so many different areas. And Sam has an ability to listen and connect with others by learning how they view and experience the world. He has an ability to understand and process information. That's something we all need to do. So, and especially in what you're doing now. He loves stories, whether reading a book, watching a TV show or movie, or actually playing a video game. And he loves, so it's interesting, the two of you can connect, Morgan and Sam, with video games. And he loves nature, especially watching the sunset and experience the magic of twilight when the sun has gone down, but darkness has yet to emerge. So what a wonderful thought. And then Michelle, her main strength is perseverance. If she's committed to a task, she's going to stay the course. So very similar to what you have, Morgan. She's very creative. She'll make it happen, even if it has to be brand new. She's willing to be the first, and she's brought these ideas and goals to her life. And she's extremely adaptable. She's always willing to deal with challenges and changes that happen. Anybody else have changes at work? And she's willing to adapt and very resilient with that, and even in her personal life. So just a little bit about our panelists to give a full picture. So I'm going to ask each of these former consumers, current working peers, to think back to when they or their child were receiving hospital or residential or school services, and to think about those who they serve right now. And they'll answer the questions that ask based on either their own experience or the experience of the peers who they're working with now. I mean, the families and or the consumers. And the audience are going to be able to ask questions after this too. But I've let the panelists know that if anything is triggering, or if they just don't feel up to answering a question from either me or a audience member, that they can just say pass or not now. So why don't we start with you, Morgan? Think of staff in the hospital who helped you or helped the people you serve. Describe the behaviors that are of staff that are very helpful.
Yeah, I think majorly is staff that are able to listen, right? Staff that goes in with the attitude of not what's wrong with you, but what's happened to you. Thinking about, everybody experiences some sort of trauma. When I was in a psychiatric facility, I was sat down by a peer and they shared their story with me. And that was the first time that I really felt seen and heard. And it gave me a better sense of myself, because they were talking to me. They weren't talking at me. They weren't talking down to me. They were just talking to me like I was a peer. And I think that really made the difference for me to de-escalate, because they were concerned with, you know, what was going on with me, and they wanted to listen. They wanted to help. They wanted to support. And that story really stuck with me throughout my life. Today, I use it all the time in my recovery story, that, you know, hearing someone else go through a similar situation, as I was going through myself, really helped me through that time.
Thank you so much. Sam, let's go to you with that same question. Think of staff, either your own experience or those you serve, who were really helpful.
Yeah, I mean, the first thing that I think made a big difference for me is kind of just kindness and openness. Like, not every time, but when someone just smiles and says hi to you and says your name, like, you don't know where someone is, and that it might not be a big deal, but it could be the difference kind of between their day being successful and not being successful. Kind of being supportive. There were certain behaviors that I wanted to accomplish that I struggled with. And there were people who were willing to sit with me kind of until I learned how to do that and could get it as part of my routine. And also just kind of as a perspective thing, kind of the perspective that you're working with someone to help them find the tools they need to heal themselves.
Thank you, Sam. Really well said. And Michelle, how about you as a family member? Think of staff when your own child was being served, and what was helpful of that staff with the family member.
So with my son was placed in a residential treatment center and moved on to a group home, and he the staff, I had one specific staff that just took us on and treated us like we were his family. He made sure that he communicated with me in every sense of the word on anything that was going on with myself. I mean, with my son in that group home. He became like a figure, an adult male role model figure for my son. Taught him how to fish, got him on football teams, made him a part of the community where he was placed. Our family had taken my son in, the coach, his family. So my son was staying with his family at the high school that he attended. He got scholarships to John F. Fisher and other colleges for football. So this staff just went above and beyond for us and treated us as if my son was related to him and not like he was in a facility at all.
Thank you. Michelle, we'll stay with you with the second question. Was there ever a time that a staff had behaviors or interactions that were hurtful to you or your child? And can you describe things that weren't helpful?
Yeah, just being dismissive toward me, or not having a concern for how I was feeling as a parent and needed to know, you know, like just dismissing me, dismissing my questions, uninterested in me and my care and concern for my child. And that's on my personal experience is what I'm speaking of. You know, I hope I answered that.
No, good, Michelle. Thank you. Appreciate it. So sincere. Morgan, how about you for yourself or the consumers, the persons you work with? Is there things that staff have done that were hurtful?
Yeah, I being at Bridgewater, I have seen many people be restrained and secluded, and I know you guys have been talking about this week, but it's re-traumatizing. And I think for someone, a staff member not focusing on the person's goals and their interests and their needs and what they need to feel safe, I think is like one of the biggest things you need to do in that moment. And I've seen staff not really care about what the person wants out of life or what they need in the moment, rather than just, you know, kind of like Michelle said, dismissing them or focusing on the diagnosis, which I just hate. Sorry. Yeah, so that's my answer.
Okay. Sam, how about for you?
Kind of the two specific things that come to mind for me. One is shaming, the same behavior that at one treatment center, a clinician was willing to sit with me until I was able to add it to my routine. At another treatment center, they simply tried to shame me into changing my behavior. At the same place, they had threatening behavior. They were telling me that if I didn't do exactly what they said, exactly the way they said it, that I would never heal. And I don't think that either of those two behaviors are helpful. And I go as far as to say they're hurtful.
Okay, thank you. So Sam, we'll stay with you. If you or if somebody you've served as a peer partner, peer advocate, has ever been restrained or secluded, what could staff have done differently so that whatever issue was causing upset would not have ended up in escalation? Or if you've observed it as part of your work, what could have been done differently?
My answer to this might be a little different than others, but I am pleased to say that in all of my experiences in multiple hospitals and multiple treatment centers, I've never seen it necessary to be used.
Okay. And so basically you're saying don't use it, try everything else, do whatever it takes.
Yeah, and that it's possible for that to be successful because my experience has shown me that it can work that way.
Okay, both where you were. Okay. How about let's go to you, Michelle. Is there, when you've seen restraint as a family partner in the unit, or if it happened to your own child, what would you say, what could staff have done differently so that to keep someone from escalating, to keep a person from escalating?
I haven't seen it here. Here they don't restrain. In my child, as far as I know, has never been restrained, but I did work in a school and have observed restraints at school. What I feel like, sometimes I feel like the worker, teacher, staff needs a reset, not so much the child or the person that's in the crisis at the moment. Sometimes the adult is fueling and causing the child to be restrained. So my experience is that they could do something different, like remove the person that's causing the behavior,
Or self-remove.
Yeah, take a moment. Sometimes a different face can change what's happening. A different person can change what's going on at the moment, where that child or person, they could just be a calming factor to the person at the time. So just for a reset for both parties, the child and I'm using child because that's who I work with, but the child or the adult could use it. I don't always see it as the person that's having the crisis needs the restraint. Sometimes it's the opposite. The caretaker could be removed and let another caretaker step in.
Thank you, Michelle.
Mhm.
Dana, how about you have a lot of experience now, with this. What do you see that staff could do differently, either with a particular situation or broader, just as Michelle did? What are some, as a person who's been, served in a hospital and as a person who's now a peer, and what do you see as necessary?
I think for me, when I was restrained and secluded personally, I got that notion of that saying, lock it up and throw away the key, right? And it was dehumanizing and degrading, and I felt like I was worthless. So I think what they could have done better here at Bridgewater, for example, I think we need more training on de-escalation techniques. I think people need to come in from the notion of there is trauma here and behaviors might not change if we do this. It may make the behavior worse. So I think also bringing a peer into the de-escalation tactic, right, would help as well, knowing that, you know, I've been in their shoes, I've been restrained, I've been secluded, I know what it feels like. So let me try and get you to a point where we don't have to use that. Let's do everything in our power, everything else before we get there. That's what I would say.
Thank you, Morgan. And staying with you, have you seen, either for yourself or for those you serve now, times that someone maybe could have ended up in a restraint seclusion and they didn't? And what were staff doing that really supported that person to self-regulate, to move in a different direction?
Yeah, I think talking and listening to them as on a human level, right? Getting to know what the person needs. You know, maybe it's they need more food or they need more clothing, or, you know, it could be something as so simple as you just need to get them a snack, right? So really hearing what they need and adapting to that is really important. I've seen people that have come in on a human level that have actually really, it's worked out in their favor, where they didn't get secluded or restrained because they felt comfortable, they felt safe, they felt like someone here has their back and they're going to be okay. And I think that's the biggest thing is, and like Michelle said, take a reset. If you feel like you need someone to hop in for you, don't be ashamed. It's not you failing. It's maybe a different set of eyes, different words, right? Words matter, you know, so what we say to people in these moments of crisis is important. You know, it's so important. So really just talking with them on a human level, I think is one of the main things that needs to happen, and listening, reflective listening.
Thank you, Morgan. And Sam, we're going to move to you for this same question. And given that you're saying to the world, no restraints and seclusions ever, you know, when you, what was done when it wasn't happening? What were people doing when somebody was really upset to keep them from escalating to an unsafe situation?
I'm actually gonna go on with the theme that Morgan mentioned in her last answer, which is getting a peer involved. I think that especially during times of crisis, it's really easy to interpret staff at hospitals or treatment centers as authority figures. And oftentimes in people's past, there are experiences different for everyone, but where interacting with authority figures doesn't go well. And so by bringing in someone who may be able to relate on a different level, it just opens up another avenue to de-escalate.
Okay, good. And what about, Sam, when those times when the peer isn't around, you know, it's nighttime, or what have you seen things that have really been supportive, or something that happened to you that was supportive, or recommendations for this wonderful audience that we have who work, as you know, in hospitals for adults, children, residential, corrections, schools? What have you seen as?
Listening and understanding, and kind of trying to be able to take it in from their perspective. Not always, but oftentimes kind of there is a compromise or a solution that can be reached, but the only way to find it is kind of if you're listening to the party.
Okay, thank you. And so, Michelle, to you now with this question, when you see in your program that used to do a lot of restraints and now doesn't do any restraints, you said, you know, what is it that people are able to do? What are things that are happening that you think has really made this difference? Oh, we're not able to hear you.
It's a lot of what everybody else said, a lot of listening, just caring, putting yourself in somebody else's shoes. If you put yourself in a person's shoes, then you could begin to feel what's going on. And I see a lot of that happening here where I work at, like a lot of people putting themselves in these children's shoes just to get a sense of what they're feeling. You know, a lot of listening, lots of communication, you know, so it's mostly what Sam and Morgan said as well. But here's a lot of listening, a lot of communication and talking these children through.
Thank you, Michelle. And I'll stay with you. We're now moving to, the important role of family partners or advocates and consumer, peers, who are, all three of you are one of these, and how these roles, I'm asking the question about how do these roles first, how do they support the other staff in the program? So how does your role, Michelle, as a family partner, support the other staff? We'll get to how it supports families and the peers you serve, but how does it support other staff having a family partner in the program?
With my role, sometimes a case manager or the social worker cannot get through at all, has no relationship whatsoever with a parent here. And I may have to bridge the two, the social worker case manager with this parent or, whomever. That's what I look at myself as, a bridge in order for the parent to trust the people that work here. I have to go out. I travel with them to the homes. I'm on calls. I'm on Zoom. I'm on, sometime there's meetings and I'm on the phone with a parent. I'm on a phone and the parent is on the Zoom and I'm texting the parent to stay calm, to be a listener, so it's those kind of things for me,
Okay, good. Let's move to you, Sam. How about your role as a peer support staff? How do you think your role works to support the other staff who work in, whether it be residential or hospital or schools or other programs? How does your role work and support staff?
I think it just offers a different perspective. I think it's a strength to be able to pull from different experiences and different perspectives in terms of trying to figure out the bigger picture, trying to come up with effective strategies. And I also think it gives the staff a different avenue to connect. So yeah, just being able to offer a different perspective and a different ability to connect.
Okay. And how about you, Morgan?
So for me, I am a participant of the new employee orientation. So the minute I get to the orientation, I first say, listen, here's my email. I'm also open to meet with staff if they need support. We run Equality Heart Circles here, which is formerly known as Recovery Dialogue, for staff as well, which really helps. It's just basically a room full of people listening, communicating, no debate, no crosstalk, just really sharing how they're feeling. I think if you don't use self-care, I try and spread self-care as much as possible here, because if you don't take care of yourself, how can you support someone else, right? So I really try and stress that here to my colleagues. And I think kind of going on what Sam and Michelle said, being that bridge, being that person that you can kind of share your story, right? I've been sharing my story all over Bridgewater with people so that they understand, someone that has been in very similar, who's been arrested, who's been secluded, who's been restrained, who's been all of these things, is now in this position where she's supporting people. So having them realize that, kind of, it gets rid of the judgments, right? It gets rid of the judgments that these are just people that have, either made a mistake or have just hit a road bump, and we're there to help. So I think, really getting a different perspective from a peer is important.
Thank you. Morgan, we're going to stay with you in the same vein of the role of peer support staff. And so we're talking about how you support staff. Give some examples of how you're supporting the people you serve.
Yeah. Oh, were you finished? Sorry, I didn't mean to.
No, yeah.
Okay. So I run about 20 groups a week where I do everything from wellness recovery action plan to all different types of groups, recovery related groups. I also see about 10 persons served individually for 45 minutes a week. So that's kind of my setting. Now, I think the biggest and best part of my job is when I'm sitting with someone and I share part of snippets of my story and they realize that light bulb goes off and they realize, oh shit, excuse me, I'm not alone, right? I'm not alone in this. There's someone that has been there. That's someone that has walked in my shoes. They might not have experienced the same thing as me, but they have felt that pain that I have experienced. And that's where the mutuality is built. That's where the rapport gets built. That's where the trust comes from. And then I think that's the biggest thing going forward is having that trust, being the backbone for someone when they're having a really crappy day. Just be able to say, hey, what's going on, man? What's going on with you? Let's work this through. Let's talk this out. So really using my experience has been key to my success for sure.
Well, very well said. And it's when you're talking, I have this kind of image is like, you're like way downstream. So it's not just when they're having challenges, like right there in the moment that could escalate to a restraint. But you're talking about your eyes and ears, other eyes and ears with staff to really address it very early on.
Yeah, so that it doesn't result into that, so we don't have to restrain and seclude. We try and do everything possible here and really just connect on a human level on a daily basis so that we don't have escalations that turn into a restraint or seclusion.
When you talk, Morgan, I almost feel like you're this comfort room walking through the hospital, everybody
I hope
gets
so.
comforted as you go. Sam, so follow up in the same way, like, we talked about how or your role as a peer can support staff. And how about like just sharing how it supports the youth who you serve?
Definitely kind of the ability, everyone's experience is different. But I really like the way Morgan phrased it when she said that kind of, even if you have a different experience, you can understand that you're feeling a similar pain. And so just the ability to form that bond. But the other thing I think it can provide is hope. I know kind of from my perspective, when I was in hospitals and treatment centers, seeing someone who was even just a little bit ahead of me gave me hope that it was actually possible. And so kind of being able to see someone who has had similar experiences, who's been able to find their way back and is now in a place where they can be a productive member of society. It's one thing to say it's possible. It's another thing to see it.
Wow, great. And that hope permeates the whole program too, because then there's something else. So we have Morgan walking through, being a comfort room, and you're a star of hope that walks through, so it lifts everybody up. And Michelle, what about this same question about, you shared how that you as a family partner really support staff and that bridging that you do, but how does a family partner now support the family members? What are some things that really help? We had a great question earlier today where an audience member shared how, that they weren't able to connect with the family member, to get them to be, what do you do to get them at hello? How do you get them to this place?
It's walking in the door. It's just, as soon as the family comes, the child is admitted, I'm right there from the moment the mom gets here with the child. I'm not even saying when they get. Prior to that child coming, I'm on the phone, introducing myself to the parent, finding out what their child likes, what comforts their child, what foods. And then when the mom gets here,
it could be more than it could be more than a mom though, right?
Yeah, a family member. But I'm the first person to greet them, and I'm the person to introduce them to all the professional staffs, like the social worker, case manager. So they with me from the moment they get here. And then through the process, I'm making daily phone calls and checking in. I support them going to court if they have court. finding resources if that's needed. I attend meetings and I'm here, like if they call a dorm and they can't get through, I let the parents know that I will leave my office and walk over and go let someone know that this parent is trying to get in touch with their child. Go back to my office, call, let them know that I did, and someone should be calling them right away. So, and during meetings, where some parents are just not being heard or understood, I tend to do a lot of like being on the phone with that parent and texting that parent to take deep breaths and just to get through, keep the voice low, so they could be heard, talking them through. So that's some of how I support. And we do have support group meetings twice a month as well.
What I envision when you're talking, Michelle, like as we're envisioning the hopes, Star of Hope and the comfort room, is that you have this like meeting, you seem to meet them where they're at, and that family members then are right, they're willing to come with you, and to walk the path with you. And it's just such a beautiful image that you presented. So thank you so much for that. That's wonderful. So Sam, I'm going to start with you this time. This is my last question, although it might veer off to another question. But if you now were put in charge of, let's say a hospital or a residential program, because you've been served by these, what would be your 3 top wishes for that program to truly support the persons being served in that program? What would be your 3 top wishes?
Not in any particular order, but one, I think peer involvement is really important. And I know that that's been changing in the field, but when I had my experiences in treatment centers and hospitals, there were not peers present. Another part would be, and again, this isn't always possible, but if possible, some kind of social engagement, even if it's just kind of going for a walk in the community. There can be a really big adjustment between kind of being in a facility and being back out in the community. And I think forming some kind of connection can help with that. And the other would just be aftercare planning, kind of being sure that people have a good plan with details to kind of support them after they leave. Because again, that is a really big adjustment.
Okay, thank you. You are succinct, I tell you. You're a good thinker. Michelle, we're going to go with you because I'm trying to get everybody, first, second, third, and so if you were in charge of a hospital or residential program, what would be your 3 top wishes be to support the families and the people served? What would be your 3 top wishes?
My first one is just to stay in communication with families. Sometimes families don't know, and it's just difficult for them when they're not communicated with on a daily basis. And my second one is your language and vocabulary usage. Sometimes like the way things are presented to families is just, they don't understand it. If it could be put simple, I would like for things to be put simple. So, it's understood, and, just work with what you have. And my last one is to make families just feel at home, where it doesn't feel so institutional. You could make a family feel like a relative, or they're included here, or, felt special, so to speak. Those are my 3.
Thank you, Michelle. And Morgan, what about you? If you were, moved from just being a comfort room to everybody and to becoming the lead of your hospital, what are your 3 top wishes?
So I'm sure these will change over time, but 2 of them are actually kind of already were brought up. So one, not in any particular order, one would definitely be peer involvement. I would love to have a peer on every unit here at Bridgewater. I think it's so important for the first face that the person served see is a peer, and that does not happen as of right now because I am the only peer here as of right now. So really getting that first person as a peer, okay, I can relate, there's mutuality there, there's support, I feel supported. Also having peers be able to, going along with that, interact with family members, I think is so important. I've had the opportunity to get to meet some of the families that I work with, their person served, and it's just amazing. Two would be, right now I'm in the Culture of Recovery project here at Bridgewater, which is all about trying to get Bridgewater to be more trauma-informed care. And everyone had to participate in emotional ECPR. And I think that would be huge if staff got trained in emotional ECPR, really coming from a point of really feeling what the other person is saying with emotions, right? And listening skills. And then the third would have to be language. Human experience language is what we learn as peers. And I think really getting, like what Michelle said, in layman's terms, right? Sometimes these clinicians and social workers and psychologists talk in these words that families just don't understand, or the person served don't understand. So kind of going in with the idea of, okay, let's not focus so much on the diagnosis. Let's focus on what this person's goals are, what their interests are, what makes them want to motivate to be in recovery, I think is so important. And using human experience language is just, I think it changes the game, you know? Thank you. Sorry, that one was a little long.
No, you all, in fact, I had asked all the panelists to know that, you know, there's supposed to be 4 of you, but, you know, like give time for everybody. And you all just are so succinct. It was almost like, oh, I want to hear more of you. I want to hear more of what you say. So when you, Morgan and Sam and Michelle, as we kind of wrap down the formal part of me asking the plan questions, is there anything that you wish you had, you know, shared, or that you wanted to, you remember, like, oh, I would like to add this? Remember, you have this audience now of staff of all kinds, you know, from top leaders, you know, through top direct care staff, you know, you have everybody there. Do you have anything that else you want to share with them in terms of either the role of peers or their work and to support the people, the families, and or the persons they serve? Anything that you wanted to add and we haven't had a chance to, you know, we didn't get to it, or you wanted to add something to anything? Should I call on you, Sam? You want to go first? I mean,
sure. And I mentioned this a little bit, but kind of just, again, the difference in perspective between I'm working with you versus I'm dictating to you. And I think that can make a difference in terms of response. And I think it can make a difference in terms of effectiveness. And I think it can make a difference just in terms of experience. Yeah.
Thank you. Okay. Michelle, is there anything, I didn't quite go the right direction, but that's okay. Anything you wanted to add in terms that maybe you wanted to say?
Yeah, just 2 things. Just try to remember that before these people got to you, that they've been through a major fire, like before they got to you, and just try to understand that they are already emotional. And like Sam said, just, you know, inclusion is very important. Just making families know that they are included in their process.
Thank you, Michelle. And Morgan.
Yeah, I think kind of what they both said, their answers have been amazing, Sam and Michelle. I think really the communication is key, right? Really communicating with someone on a human level, getting to know them, getting to know what they like to do, and utilizing peers. I think so many people don't understand what peers do or who we are. And I think it's so important to have a peer in any kind of setting that uses restraints and seclusion, because we can relate on a different level than maybe someone of a different title, right? And I think it's really important to have that opportunity for the person served to get to communicate with someone that has experienced that, like I said before, that same pain. It's so important. And just treating people, treating people with compassion, like Michelle said, knowing that, they've been through probably hell and back before they get to you. So really going in with no judgments, just kind of on a human level, just saying, what can I do for you? What can I do to support you? How can I be of help to you? Because I know where you've been and I want to get you out of there. Recovery is possible and probable. I will say that. And that's kind of what I look for when I support someone, look to
Wow.
go to.
I think it's wow, you all have been so powerful, and thank you, Morgan, Sam, and Michelle. And I think that what was double powerful is that, Morgan saying that she knows this person's been through hell or whatever, it's the fire. And you're saying the same thing about the family members been through that too, so it's both of them have been through really, really challenging times. So I couldn't have, if I was Oprah, I couldn't have put together a better panel. This was most amazing panel. And I'd like to open it up to questions from the audience. You can either put it in the chat or Dana can see your hand raised and call on you. So any comments, you can have comments from the audience or questions from the audience, first for our panelists. And then again, remember, you can also, Kevin's here if you have any questions about that tremendous transformation that they're still focused on and working, but that happened at Bridgewater. So how about any comments or questions from any audience member to any of our panelists or all of the panelists or to Kevin?
Minta, please go ahead.
So I have a question for Michelle, actually. Thank you to all the panelists. My question is for Michelle because I'm at a facility, residential facility for children. My question is, when you're doing residential treatment, because that involves, having the child out of their home for a while, it's very easy for the general public to get this idea that it's kind of like taking your car to the mechanic, right? You're going to drop the kid off, they're going to do treatment to the kid, and then the kid's going to come back and everything's going to be fine or at least better. And Michelle, my question for you is, in your experience, what do programs have trouble communicating to parents in terms of the expectation for the parents' role and the parents' participation in treatment? What could they be doing better in terms of communicating and supporting those expectations? And or have you ever worked with a program that actually has done a really good job of communicating those things?
I have worked with a case manager that goes above and beyond with families and that expectation. Sometimes it's just, you can't give up. You just gotta keep trying to communicate with these parents. And sometimes I do say to parents that your child is here getting what they need. And if I can't with my job and my job title, it's not to tell parents what to do. I only could talk about my experience and what I went through as a parent who had a child that resided in a residential treatment center. So it works. Sometimes that works, and the parent may get the understanding. And, I explain a lot of my experience. So, that's the only way I could answer that, is just by experience. And I work with some great people here that go above and beyond with families. And, we kind of like work alongside one another to have parents see or understand what their child is doing here and the treatments that they get in here. And sometimes they jump on board, and then there's some that we have to work really hard. At the end of the day, we do end up on a discharge, and I'm still working with families even after the child is discharged like 6 months after. I hope I answered your question.
Yeah, no, great. That's great. Thank you so much.
Mhm.
Okay, anybody else have a comment or a question for Michelle, Morgan, and or Sam?
Hey, Beth, I do. This is Kevin.
I think I know you.
Okay. Well, there are three things. The first is something that Sam said, and that was about helping people heal themselves. And I think that is really important for us to constantly remind ourselves that when people come to us for services, we're not supposed to make them into forever patients, right? We're supposed to, that's the whole point of treatment and having them come to us in the first place, is to giving them a safe place to start to practice new skills and learn new skills, so that they can then manage when they leave better than they did before. And sometimes, like in terms of substance abuse, sometimes you do it 10, 12 times before you actually get it, the tools to stay sober. And the same thing is with mental illness and serious emotional disturbances, especially related to trauma, is that it's like Beth talked about when she did the neurobio presentation. We all have to learn to self-regulate. And in many cases, the folks that have come to see us never learned that, or they didn't have a place to be safe to learn it. And so they're still reusing survival skills that are not pro-social or things that can be used really safely in the community. So we're there to help point people in the right direction, but it's their journey. So I just wanted to highlight that Sam said. And then Morgan said something that just always resonates with me about being non-judgmental. And I just think that we constantly have to remind ourselves of the power differential. As staff, we have a lot more power than the people we serve. And so it's really easy to be judgmental. And sometimes it's almost unconscious. So we really have to constantly sit up and take a breath and say, wait a second, I'm not a parent. I don't have the right to punish. I am here to help, be compassionate, empathetic, and to give someone voice and choice and options so they can make their own decisions, even if I wouldn't make that decision. Sometimes people learn the best by making the wrong decision. And that's just the way it goes. And it isn't a smooth pathway. And then Michelle said that the whole issue about listening. I have this thing I always talk about, which is learning about the person's story. Do you know how often it is to come upon someone in care who's never had a chance to really tell their story? And their story is an individual story. And sometimes it's just so freeing and cathartic for a person to just tell their story and be listened to. Don't give advice, nothing like that. Just listen to their story. So I just wanted to call those three things out. Thank you so much, guys. You're just something. I don't even know what to say. I'm speechless.
They were wonderful. Is there somebody else's hand up, Dana, that you want to ask?
Yes, there is. I'm going to go to Brenna in a moment, but especially for Morgan, since she's joining by phone, I want to make sure that we point out a couple nice comments in the chat, including from Susan, who says, hearing from Sam, Morgan, and Michelle is so critically important. For them to choose to come back and provide thoughtful care, educate, and advocate from their perspective is absolutely powerful. The three of you are amazing humans and are surely impacting lives more than you realize. For certain, thank you. I thoroughly enjoyed this conversation. I am grateful to have the opportunity to be here. And Jeffrey has similar sentiments that he shared. So thank you. Brenna, you had a question or a comment?
I do. Hi there. Sorry, I've had so many questions, and part of it's because I'm in this unique situation where I'm the new director of clinical services for a hospital that's not open yet. So we have the chance to kind of do things right from day one. And I wanted to ask the group, what are some things that I can do to support peers who may want to work here and to reach out to the community and let the peer community know that, you know, I would really love to have peer engagement and peer interaction kind of right from day one.
So that's for you, Morgan and Sam and Michelle, but Morgan, maybe you want to start with that? 'Cause is it an adult hospital, Brenna?
13 and up.
13. Okay, so adult and children. Okay.
Yeah, I think back to listening, right? Listening to the peers, getting their input. I think there are so many ways, so many different kind of like group ideas, so many ways that peers can get involved, whether it's the admission process or the discharge process or just working with people individually. I think it's so important that a peer can be prominent in your setting, and just like listening to them, hearing their story, listening to what they've been through, listening to the challenges that they've overcome or that they've seen in different hospital settings and really adapting to that. Thank you. That's a great question.
And if I could add to it, just making sure that your staff understands that the peers have lived experience. Making sure that staff understand that peers have lived experience, because sometimes it's not, some staff don't understand that part, that peers have lived experience. I mean, where you know, I just wanted to get that out. And there was another thing, I just lost my train of thought.
That's important, Michelle.
I'm sorry.
There's adaptations that need to be made often for the peers served.
Mhm.
So thank you. Sam, did you want to add anything for Brenna?
I feel like my peers gave really good answers. Kind of just the one thing I would say is if you're looking for them, I know that the certified peer specialist training is still ongoing, and so reaching out to them maybe to find a way to connect with their alumni.
Are you able to put in the chat, Sam, how to connect with certified peer specialist training?
I mean, I can put in their website. I don't.
Why don't you put that?
Like,
yeah, put it in the
I can find
their
that
website in the chat. If you could just,
you got it,
everybody. Thank you, Sam. That's great. That would help everybody. Okay. Anybody else? Any other comments, questions, thoughts? Dana, do you see anybody's hands up?
Nope.
Beth, can I add one thing to the last question?
Yes.
Also, I think knowing that like us as peers follow a strict ethical code of ethics, knowing what those code of ethics are that we follow is really important. I find that at my job, sometimes I have to push the boundaries of my ethics at times because what the job entails that I do. So kind of knowing where we stand as peers is super important and what our code of ethics are.
Great. And for Morgan, I don't know if you can see the chat. Thank you, Dana, for this idea. Somebody, I think Coles wrote, I would like to mention the experience I have working with peer specialists is tremendously valuable. Having peer specialist on a unit as part of the team made a huge difference in my experience in this field. So go team. Okay, well, if no other questions or comments, it's like I don't want to let Brenna and Sam and Michelle go because they are that comfort and that hope and that bridge. But if everybody could they could see you like kind of just doing your kind of clap, how do you do that silent clapping, Thank you so much to each of you. Just wonderful. Yes, just great. And Sam did put some things into the chat box. Thank you, Sam. That was really helpful. People can do that. And we are going to see hopefully all of you tomorrow when we focus on finally prevention tools that are really getting into those very specific tools we're going to use. And then probably after leadership, one of the most important areas is debriefing and prevention and how to do a plan for your program. So Thank you to Sam, Michelle, and to Brenna, and thank you to
Morgan.
Kevin and Morgan, and also thank you to Kevin and to Ken who presented today, and Dana's doing everything, and to all the audience members who have obviously been listening and paying attention, and just really we feel connected to all of you. Kevin, I don't know if you want to say your goodbyes too.
Yeah, just don't forget to fill out your evaluation, folks, if you want a certificate or CEUs. And hopefully we'll see you all tomorrow. And thanks to the panel again. Bless you.
Okay, thank you all.
Bye.